Thank you. In most patients with obstructive jaundice, the endoscopists can do very little, only palliation, because these cases come to us beyond resection. And all we do is put in these stents in these patients, sometimes plastic stents, sometimes metal stents, to improve the quality of life, but we can't make any difference in terms of lifespan in these patients. However, in recent years, there's been several intraductal luminal therapies that are coming up that seems to change this, so that as endoscopists, not only can we palliate these patients, but probably also provide them an increased lifespan and a better quality of life. There are several intraductal therapies that are available, and I'll just go briefly give an overview of what is currently available. Brachytherapy for malignant obstructive jaundice has been there for very long. And in fact, several years back, we demonstrated that you can actually put a nasobiliary tube into the bile duct in these patients, put iridium wire, give local high-dose brachytherapy, and prolong the lifespan of these patients. And you can see significant prolongation lifespan. But the problem with this treatment is that these wires are thick. The industry has not been very interested, so they're not decreased the size of the wires. The radiologists have used it percutaneously better, but for endoscopists, the limitations has been the availability of thin wires. And therefore, this is a therapy that didn't go on very long. Although, if you look at the literature, a lot of it from radiological literature, you'll see that the average lifespan of these patients has been prolonged by about 4 or 5 months after using intraductal brachytherapy. And you can see that from 4 months to an average of 11 months. So therefore, this is a very promising therapy, but unfortunately didn't pick up because of lack of interest from the industry. There have been, in fact, reports of patients living much longer, and this is a report of a patient in Chinese literature living for more than 8 years. This form of intraductal therapy has also been very effectively used for patients for pre-transplant. Cholangiocarcinoma patients who have to go for transplants at the Mayo Clinic have a protocol where these patients are first subjected to intraductal endoscopic directed brachytherapy, followed by chemotherapy, and then transplant with 5-year survival rates of almost 75%. But unfortunately, as I said, brachytherapy hasn't progressed much. What about giving radioactive stents? This is a very interesting concept where, again, Joshan Lee's group from Shanghai have used this. They have impregnated standard biliary stents with radioactive iodine pellets, and these are put in along with the standard biliary stents. And in a short series that they published, they have shown that you can prolong the lifespan in these patients. But again, we haven't had long series coming from this. What has been most frequently used form of therapy is photodynamic therapy. And this is something that has been extremely popular in many centers in US, in Korea, and so on. The principles of this therapy is to give a compound like photofrin, and this is followed by ERCP, and exposing this compound gets concentrated in the malignant cells in the bile duct, and then you expose this bile duct to a laser of certain wavelength, and the cells are killed. It causes reduction in cholestasis, improved quality of life, and improved survival. In fact, a stricture like this, you can give the photofrin and later subject these patients to endoscopic therapy with laser, and then the stricture completely opens up. The first reports were anecdotal reports which came from Germany, from Ottner's group, which showed that patients with resistant cholestasis could be treated very effectively with this. And soon followed 2 randomized controlled trials in which PDT was compared to PDT stenting versus plain stenting. And both the studies showed that if you combine PDT with stenting, you can prolong the lifespan of the patients. In fact, double the lifespan of the patients. Ottner's study, which was published in Gastroenterology more than 10 years back, had to be terminated for ethical reasons because the lifespan prolongation with PDT was much, much higher than standard stenting. So therefore, they had to stop the study, saying that it should be a standard of care to use PDT along with stenting in these patients. So this has been shown to be effective. And some recent reports also would suggest similar thing. You can see Hilar study again showing that PDT is much better. And you can see the survival when using PDT along with stenting versus plain stenting in these patients with malignant obstructive jaundice, you almost double the lifespan in these patients. And there are again several reports in literature which are shown, just like brachytherapy, by using PDT instead of just stenting, you can prolong the lifespans in this patient. So this is a therapy that has had very encouraging results. However, there's a problem. The problem is the cost. PDT is extremely costly, and an average session would cost $4,000 to $5,000 per session for the patient. And second, in countries where, like especially in Asia and probably Greece, where there's a lot of sunshine, it's very difficult to do these therapies, because after the therapy, the patient should not be exposed to sunshine for at least 4 to 6 weeks. Otherwise, he'll develop severe photodermatitis. So therefore, in these countries, it becomes extremely difficult to use this form of therapy. What is the other alternative? And now what is exciting is recently the availability of radiofrequency ablation to treat these patients. The principle of radiofrequency ablation is just like the principle that we use for hepatocellular carcinoma, to use heat to produce coagulative necrosis of the tumor. And once you can do this, you can completely coagulate. In fact, for the hepatomas, which are 3 centimeters or less, the consensus guidelines now suggest that you can use a radiofrequency ablation, which is equivalent to surgery in these patients. And therefore, why not we do it for malignant obstructive jaundice? The first studies came from this group from the Imperial College in London. This is the Nageshwar catheter that has been used with this generator. This is the Rita generator, but you can also use the other generators like Irby generator and so on. These are the generators that we use. And what we used to do in those cases is to use 10 watts for 2 minutes, use it through the ERCP probe. And the first study, again, proof of concept study, showed that by using this in patients with malignant obstructive jaundice, they increase the stricture. This is the Nageshwar catheter that we use. You can see this catheter has got 2 steel rings here, which are actually a bipolar catheter. Heat travels between these 2 rings, producing a 2.5 centimeter depth of length of injury. A depth of injury will vary upon how many watts we use. When you use 10 watts, it's about 0.5 centimeters. If you use longer, you can get a much deeper burn. You can see a video here of how this is effective. This is a baby scope picture that Horst just showed you, showing the tumor here. And once we see the tumor, you put the ring catheters here, burn, and see immediately afterwards there's a deep scar like you get in a Barrett's esophagus. The whole thing gets burnt white, and you can see this. The stricture opens up completely, and a narrowband imaging of the stricture to show that you completely burn all the blood vessels, and it's opened completely. Immediately after the procedure, it's a very impressive. You can see that it's opened up here, and these are pictures to. And even for very tumors which are right up there in the hilum, you can use it very effectively. In fact, for Hilar tumors, we use a much longer voltage. We use up to 20 watts, sometimes going up to 3 minutes. It's very safe, and you can see again the white scar completely burnt, and then we can go through this very easily. So this is a very effective way of actually intraluminally burning these tumors completely. The question is, does this increase survival? Just burning the tumor here, is it enough? You can see this before and after, immediately afterwards. And similarly, the baby scope, cholangioscopy pictures before and after with opening with RFA. We have actually looked at a couple of our patients with cholangiocarcinoma, mainly in the mid-upper part of CBD. For low end of CBD, we don't use this very common because the chance of pancreatitis is there, and most of these cases are resectable. Those who have a locally advanced tumor, those who are contraindications for surgery, are the ideal indication for this form of therapy. There are very few complications with this procedure. Most of the complications are related to the ERCP procedure itself, but in patients who have had the tumor at the cystic duct area, we've had 2 patients who developed cholecystitis after the radiofrequency burn. But otherwise, it's a relatively safe procedure with very few complications. And you can see when we looked at our patients, 42 patients followed for 12 months. At the end of this period, 17 were still alive, which is much historically compared to our historical controls is much higher. And we are now actually doing a randomized control study to look at this. Another area where we use this is in patients who have a metal stent put in. Cholangiocarcinoma, the stent gets blocked because of tumor infiltration. Then one can effectively use this technique to completely clear the stent. So we now started a randomized controlled trial where we're actually looking at plain stents versus radiofrequency ablation to see whether it actually prolong survival or increases stent patency. One of the reasons why patients with cholangiocarcinoma who are stented die within a period of 6 months is because the stents are getting blocked, they develop cholangitis. So even if you can stop the stent blockage very effectively or prolong the stent patency, then probably you can prolong life in these patients. There's some early data, this is from Westby's unit in London, to suggest that you can actually prolong the lifespan in these patients when you use RFA compared to controls. There's a new RFA technique that's coming which seems to be better, and this is from a Korean company called StarMed, where instead of 2 rings you have 4 rings. They're much shorter. You get a longer burn which is 3.5 centimeters, and it's more uniform. You can see this, it's very uniform type of burn. And we have now been using this quite constantly, and you can see this is a cholangiocarcinoma here in the mid part of CBD. You can see all the ring catheters placed exactly across this tumor. And these anyway, this is I'm not able to get the pre one, but the post you can see it's completely opened up completely. So this is a very effective technique, and this I feel is much more effective than the older catheters. Now the question is, if you're burning these tumors, coagulative necrosis, is it just enough, or how do you actually increase survival in these patients? We have again looked at some of the data in animal model, and we found that when you use RFA, for example, if you use it for 2 minutes, 10 watts, then you produce an injury of about 0.5 centimeter. But if you use it for longer period, 20 watts or longer period, then you produce a 1 centimeter injury. That's not, these tumors are much bigger, so how do you actually destroy these tumors? And the way it happens is because not only is the tumor getting burned, but there's a cytokine release there at that point of tumor. There's also immunomodulation of these tumors that are occurring because of the burn, and because of that further destruction occurs. And again, this is data from our lab where we actually looked at the cytokine levels in these patients who have had this RFA. You can see very interestingly that when we apply RFA current here and look at the cytokines in the bile, these patients had nasobiliary tubes, and continuously we aspirated the bile to get the cytokines. And you can see what happens is an increase of certain cytokines which have increased, like IL-6, TNF, have increased markedly. They come down within 24 hours very quickly. But what happens is after a couple of, after 12 hours, they again increase. So there's a second peak of cytokines. This is not because of burn injury. This is probably because of an immunomodulation that's occurring. And this is a phenomena that we don't understand why. But I think this sudden second increase of cytokine actually causes a further tumor damage, causing much more injury than what would be accepted by a simple burn of these tumors. So this is, I think, something that we are studying further. There's again some very early data, and this was presented at the DW, is going to be published in GIE soon as a full paper, which has looked comparing PDT, which we know is a standard of care in many centers in US and so on, in these patients, comparing this with a much simpler radiofrequency ablation. And this is trans study which showed that both PDT and RFA have similar effect in terms of patient survival, complications and so on. So if you compare both these intraluminal therapies for patients with malignant obstructive jaundice, which is better and which should one use? I think RFA is much more simpler. The cost is extremely low. These catheters cost less than 200 euro. There's no photosensitivity, but unfortunately the evidence is still less, whereas we have a lot of papers. PDT is old technology. We have a lot of papers still which are available for PDT. But this is coming now, and probably we are getting more and more randomized control trials comparing both. And if RFA is as good as PDT, this may be much simpler to use for an average endoscopist. Of course, there are other newer intraluminal techniques like drug-eluting stents, again from Korea, which have come, and these drug-eluting stents have shown initial promise, but we require a lot more trials in this. Ultimately, the treatment of cholangiocarcinoma, I think, is a collaborative effort between the gastroenterologist, oncologist, interventional radiologist, and so on. It's a multimodality approach. But increasingly, as endoscopists, we're getting better methods, better intraluminal techniques that seem to provide us with the capability to increase the lifespan of the patients. And finally, Mr. Chairman, sir, ladies and gentlemen, I think what is going to be the future of treatment in these patients? What is the future of intraluminal therapy? And I'll show you what. You don't have to be an endoscopist to do this. You can actually do it on a computer screen. With, you can see this, you choose your computer screen. You say which, okay, you want to treat cholangiocarcinoma, and then you get with robot or without robot, so you can actually, so you have to be good with your PC to do this. The patient is lying on the table there, the endoscope comes in and then goes, and then of course it releases a robot which goes into the, there's a robot in the bile duct, and then that is the tumor there, and then using a radiofrequency ablation ablates the tumor. So this is of course going to be the future shortly. Maybe next presentation, next Athens conference, we can show this. Thank you for your attention.
Thank you, Professor Reddy, for your excellent presentation, detailed presentation for the intraluminal therapies for malignant